Radiotherapy is an indispensable part of treatment of cancer. And most of the people rush to the chemotherapy, but I think radiotherapy is as important and is as equal as chemotherapy. I am Professor Salah Al-Masidi, Professor of Clinical Oncology, Faculty of Medicine, Cairo University. On my left side, Professor Ashraf Barakat, Professor and the Head of Clinical Oncology at Tanta University. I would like to thank the organizer of the symposium for inviting me to share this important symposium. On my left side also Professor Tariq Hussein, Professor of Clinical Oncology at Shams University. As you see, there is a collection of all universities in Egypt. May I call for the first speaker, Professor Jean-Pierre Gerard, France. The title is New Innovative Techniques in Breast Cancer Radiotherapy, Stereotactic Radiotherapy Image, Guided Adaptive Rotational Arc, and the Proton Therapy. Professor Gerard.
Well, thank you, Mr. Chairman. It is always a great pleasure to be participating to this very impressive meeting, and I would like to congratulate my friend Professor Hisham El-Ghazali for his continuous support in this Congress and meeting. I will speak of innovative technique in radiotherapy from IMRT to proton, and this is my disclosure. I have been involved in the 50 kV treatment for many years, and if you want to have a summary of what I said, you can read this paper that I recently wrote in Nature Review, where I said that radiotherapy has been driven mainly by technological improvement, that the role of radiotherapy is to sculpt the isodose in 3 dimensions around the target volume, and that the benefit is threefold: cure of patient, conservative treatment, and cost effectiveness. That will be my conclusion. One of the first good things with technology in radiotherapy is that between the discovery and the change in clinical practice, the time is very short. Here you have, in 1895, the discovery of X-rays. In December, 6 months later, Despeigne in Lyon, my mother town, was the first to treat a cancer of the stomach with X-ray radiotherapy, and 3 years later in Stockholm, it was possible to cure the first patient with radiotherapy. From the discovery to the clinical practice, 6 months, 1 year, very short. Of course, we need scientists like Marie Curie and Albert Einstein to discover the radium, the X-ray, and also to do radioprotection. Radiotherapy is the science with the best safety measure to protect the patient against side effects. Then, with the discovery of cobalt, it was able to spare the skin, which was a barrier to increase of the dose and for curative treatment. And then the first accelerator in 1953. And already at that time, with cobalt and low-energy X-rays, it was possible to transform completely the life of the patient with breast cancer. And it was the merit in Milano of Professor Veronesi to demonstrate with a randomized trial that when you compare mastectomy and lumpectomy with cobalt irradiation, you had exactly the same survival rate. And his publication in New England in July 2nd was so important that on the same day, in the New York Times, in July 2nd, studies support limited surgery for breast cancer. This was achieved 40 years ago with cobalt and low-energy X-rays. And this is my personal life. I started with Olstedt operation, then Pate operation some years later. And after the work of Veronesi, 1984, breast conservative treatment with a large scar, and some years later, no more scar. This is impressive results thanks to radiotherapy. The history of radiotherapy can be divided in 3 periods. Kilovoltage, low energy, mainly palliation. High energy, then radiotherapy started to be curative. And since now 10 or 15 years, we have a computer-assisted radiotherapy. We gain in 3D radiotherapy, and there again, this technology improvement is translating it better result, clinically speaking. And the future will be what we call hadron therapy, protons, or maybe carbons. Radiotherapy is a very simple aim, always the same. You have the dose, you have the probability of local control of the tumor. And when you increase the dose, of course, you increase the chance of controlling the tumor and sterilizing the tumor. The main and the only limiting factor is the tolerance of the normal tissue. And if you are here on the dotted line, when you reach 40 gray, already you have more than 5 or 10% of severe complication, and you cannot cure any patient. And if you want to cure patient, you must reach higher dose, but you must spare the tissue, and this is the limit, and this is the goal of radiotherapy, to increase the dose in well-targeted volume without having side effects. This is an old drawing that I gave to my students some 20 years ago, 200 kV. You stop at 50 gray because you have the tolerance. With cobalt, you can increase to 60. With linear accelerator, you can increase to 70, and then, of course, you are very highly curative. And then, after this, you have the 3D conformal therapy. You irradiate a sphere, not anymore in a cube, but in a sphere. With IMRT, you can have concave shape, but of course, at the cost of more small dose in the whole tissue of the body. And with proton, of course, it's not anymore 80, it can be 84 because you have no more exit dose. And with carbon, for the same dose in the normal tissue, for biological reason, you will increase from 84 to 100. This is the summary of technology. With lead accelerator, some years ago, one of the merits of the electrons of this machine was to produce electrons, which was able to irradiate superficial volume. And we were able in Lyon to do a randomized trial with my good friend and colleagues Pascal Romestin, where we compare 50 gray and 50 gray plus 10 gray of electron boost, and we are able to increase local control and reduce from 6% to 3% the local relapse, and cosmetic results, self-assessment, the patients were satisfied in 90% of cases. And of course, this better local control translated in France in reducing of mortality in men and in women. What has changed during the past 30 years? When I was in Lyon for 600 patients per year, here we were looking at films. It was analogic treatment, 2D treatment. There was 7 radiation oncologists and 2 physicists. Now in Nice, it is the same thing, but for the same number of patients, same number of radiation oncologists, but 8 radiophysicists. And it is everything with computer, and not anymore analogic, everything is computer assisted. This is the number of radiation oncologists in France. This is the number of physicists in France. The key of future of technology is to have good radiation oncologists, but maybe more or less, more importantly, good physicists. And of course, now everything starts in the computer, where you do the 3D reconstruction of the patient, where you see the tumor, you make the fusion with the MRI or with the PET-CT. And you have the what I call, and we call, multi-leaf collimator, which can do conformal treatment, and with this, you can move the leaf of the collimator and you can do this IMRT, intensity modulation radiotherapy. And intensity modulation radiotherapy, as I said, is able to treat concave volume that you cannot treat properly with only 3D radiotherapy. And one of the main fields of interest of this IMRT is head and neck cancer, where you have a tumor here, for example, of the tonsil, and you have the parotids on both sides. And if you irradiate the parotid, you have dry mouth, you have severe problem with the teeth, and very severe side effect for the patient. With the IMRT, you can have a concave isodose, protecting the cord, protecting both parotid, and at the end, instead of having normal saliva with 3D conformal, with IMRT, 6 months later and 2 years later, you have a complete disparition of the dry mouth, and it is a dramatic improvement in the quality of life of the patient. So, if you look at what happened during the past years, we have been with only 40 Gray for the prostate with a 200 kV, no treatment, 60 Gray with the cobalt, you move to 70 Gray with the linear accelerator, but most of all, with the 3D we could increase to 78, and now with IMRT you can protect the rectum and increase to 80 Gray. And this has made radiotherapy a very powerful curative treatment of prostate cancer, which is a very common cancer. And in the future with proton, you will spare still more normal tissue, you will increase the dose, and maybe with carbons. So increasing the dose safely can improve dramatically the clinical results. Some other technique that you have heard is image-guided radiotherapy. You can control on the table that you are accurately positioning the treatment with KV control or with a cone beam CT. For normal tissue, you have special machine like the Novalis or the tomotherapy, which can do very good image-guided radiotherapy. And the best of everything to have accurate targeting is stereotactic radiotherapy with a cyber knife. Everything is moving. The lung is moving, the liver is moving, the breast is moving, and with this machine, which is driven by a robot, you can focus permanently the beam on the moving target. And Professor Bondio, that you can see here, is driving the cyber knife in this, and he will explain you how useful is this machine to treat breast cancer in the neoadjuvant setting. Everything is moving, but the machine can move with the respiration of the patient. And if you have a tumor of the breast, you can irradiate the tumor, you can spare completely the skin, you can spare completely the lungs, you give 100 small beams directed to the tumor, and the beams is moving with the respiration and the tumor of the breast, and you have a tumor like that, neoadjuvant treatment, and a complete disappearance. With this improvement in technology, better targeting, better energy, more protection of normal tissue, what is going to change dramatically, and it is at the present time ongoing, it is the time factor, and we are going to hypofractionation. Fractionation is a very complex issue. I will make it very simple. It is the number of fraction, it is the whole duration of treatment. For brachytherapy, it is dose rate. For more than 70 years, we have followed the rule of Coutard in Institut Curie in Paris, who said you should give 2 Gray per fraction, 5 fractions per week, 10 Gray per week, 50 Gray in 5 weeks, 70 Gray in 7 weeks. At the present time, as we are sparing much better the tissue and we are irradiating smaller volume because we target better the GTV, modern technology with improved conformation will reduce toxicity, will allow to do hypofractionation. We are going to move from 6 weeks to 3 weeks, maybe to 1 week, maybe to 3 fractions, and you will see maybe to 1 fraction during surgery with IORT. External beam is a technology, but don't forget that 10% of the patient, and in gynecology you are way aware of that, are treated with brachytherapy. Brachytherapy is short, focused source discan to 9 centimeters by opposition to teleradiotherapy, which is the standard external beam. And small is beautiful. I will not go into the detail of the inverse square law, but this is the reason for brachytherapy to be so efficient. High dose in the tumor, small dose in the normal tissue. With teleradiotherapy, you have an homogeneous dose, but a low dose rate. With brachytherapy, you have inhomogeneous dose, but you spare completely the normal tissue around. Brachy, rapid fall-off of the dose, inhomogeneous, teleradiotherapy, slow fall-off, homogeneous dose. And this is, for example, in my field of rectal cancer, some example of what you can do with brachytherapy. You can do XRB, X-ray brachytherapy with 50 kV with this kind of machine, and you can shoot the rectal tumor. You can do endoluminal, like you do in the vagina, with an applicator that you put inside the rectum. You can do interstitial brachytherapy, and you implant, and you can do HDR. In breast, for example, you can do intraoperative interstitial brachytherapy. Under control of the vision, you implant the different catheter after the lumpectomy. And you see that is done in Professor Hanoun in those display. You have a very nice implantation. And the good thing that you do the implant during surgery, you wait 1 week, and when you have the pathological report, you adapt the dose to the bad prognostic factor of the tumor. This is, for example, endoluminal brachytherapy with the X-ray for rectal cancer. This is the tumor that you see on the machine. You randomize external beam versus external beam and X-ray brachytherapy, 90 gray in 3 fraction boost. And you see that after 10 years, and it is published in many papers, the colostomy-free is only 29% when you do external, and when you boost the tumor, you have 31%, and there is 9 patients who have been able to preserve the rectum. A low tumor in the rectum, complete sterilization with the contact therapy, X-ray brachy, local excision, 12 years later, patient alive. And with this 50 kV machine, what you can do is intraoperative radiotherapy. This is the intrabeam technology. This is the machine. The beam is produced by the source, which is here. This is the whole system. And during the lumpectomy, you introduce the X-ray beam, and during 30 minutes, you give the 20 gray. And you can do randomized trial that you have heard, where you see that external beam in 6 weeks compared to IRT in 30 minutes, 20 gray, same rate of local relapse. This is still controversy, but this is a way to achieve small, best good treatment. You can do the IRT in breast cancer with electrons. And you will hear Professor Orekia here in the room who will speak of IRT with electron with the Novax machine. And here again, there is a randomized trial with more than 1,800 patients with 6 weeks of treatment with 1 shot during surgery in the good and low-risk patient, no difference in local relapse. But the future is probably protons, because it has been discovered some 40 years, 60 years ago in the United States, and the first cyclotron was in Boston. And you will have here Dr. Tagian from Boston who will speak about the protons. And you see that the number of proton machines in the world since the past 20 years. You have in Europe, you have in the United States, you have in Asia, and this number will increase more and more every year. What is the advantage of proton? It is what we call the Bragg peak. The Bragg peak is that when the tumor goes through the tissue and comes into the tumor, it delivers the dose, and then it stops. This is a normal tissue. It enters the normal tissue, no side effect, everything in the tumor, and just after, you have no more X-rays. And this is what you have, the dose distribution with photon in red. You have high dose at the entrance, still some dose after you have eaten the tumor, and with proton, low dose in the entrance, homogeneous, you don't lose dose here, and after that, complete fallout of the dose. This is a unit of proton therapy in Nice. My office is here. Professor Bondio is also here. This is the machine inside. This is a treatment for eye tumor, and below you have the cyberknife. What we do with the eye and the protons, we have been doing that for more than 20 years. Now we started in 1991. A very accurate technique of radiotherapy. You immobilize the patient on a special chair with a precision of 0.1 millimeter. Here you have the eyes, 3 centimeter, the tumor, 5 millimeter of thickness, 9 millimeter of diameter. You give 5 fraction in 4 days, and it is over, and you treat 85, and you cure 85% of the patient with good vision. This was an old machine, and the future is what we call the supraconducting synchrocyclotron. The price will be reduced, still quite high. The weight will be reduced, and we have a special engineer with the company IBEA who will make this new machine that will work in Nice in 1 year, and will produce high-energy proton beam. And this will be the tumor and the treatment room. And for breast cancer, at the present time, you know that accelerated partial breast irradiation is becoming more and more popular to try to reduce the constraint of the treatment. And for this kind of accelerator, you can do it with 3D conformal, you can do it with IMRT, you can do it with tomotherapy or with proton. And if you look at the dose in the tumor and the dose on the rest of the breast, in the heart and in the lung, in all the cases, the proton therapy gives a better dose distribution. And if you have what we call beam-active scanning, you can sculpt the isodose around a rectal tumor and you can achieve 80 gray in such a tumors. And if you have a tumor in the pleura, this is what you achieve with the best IMRT, and you can see that with proton you spare much better the normal tissue. So for dose distribution, this will be very important, and pediatric cancer will be a very good target for this new technique, because you know that when you cure patient with radiotherapy, 20, 30 years later, you can have a radiation-induced secondary cancer. And this is eminently true when you have 10 years or 20 years. When you have 40 years, the risk of secondary radiation-induced cancer is very low. But for pediatric cancer, proton is certainly going to play an important role to prevent this radiation-induced cancer. And maybe the future will be carbon, because with the same dose at the entrance, this is proton, carbon, for biological reason, EBR is more efficient. And this is what you can see in Japan. The patient are here, you have the golf course here, and here is the usine where you have the machine, and the machine is here to bend the beam on that. And this is a huge machine. You produce this, you accelerate, you have isocentric machine for eyes, and here you have the carbon with horizontal beam, vertical beam, and an oblique beam. And what you achieve, this is impossible to achieve with photon or with proton. You have a malignant melanoma of the nasal cavities. With carbon, you cure it. You have adenocarcinoma of the ethmoid with the eyes protrusion. With carbon, you cure it. Adenocarcinoma carcinoma, and you cure it. In my field of rectal cancer, you have a recurrence, which is with the FDG positive. Carbon, you cure it. Carbon is in Japan. They have treated more than 8,000 patients, but it's now in Heidelberg. And here again, Professor Orecchia will give you the last result of Pavia, where in Italy they have a very nice synchrotron, which is producing protons and carbon ions. Conclusion. As the moderators say, radiotherapy is one of the most important treatments of cancer and one of the most important treatments in breast cancer. And the three qualities of radiotherapy are the 3 C's. 50% of the patients are cured with radiotherapy. Without radiotherapy, no more conservative treatment. And most of all, if the whole cost of cancer is 100, you should know, and this is very well demonstrated in France and in all the country, that the total cost of radiotherapy, investment, running costs, honoraries of the doctor, is only 10% to treat 50% of the patient. So my conclusion is technology is a main field of improvement, but we must adapt, of course, technology to the clinical and socio-economic situation of each country. But most of all, technology is great, but we must maintain a strong clinical approach. We must speak to the patient, we must examine the patient with our eye, with our finger. This is the basic oncology, and then we must tailor the technology to the individual situation of each patient. Technology without clinic will not achieve anything good. Thank you for your attention.
Thank you, Professor Gerard, for this wonderful updated review of radiotherapy. I think we will postpone the questions until the end of the symposium.
I have the pleasure to present the next speaker, Professor Jean-Yves Bondeau, Professor of Radiation Oncology in France, and we'll talk about final results of phase 1 protocol of cyberknife in breast tumors.